So, my today's topic of our discussion is hepatolithiasis classification and management. So, for the classification, what I have to know that the hepatolithiasis is defined as a stone located in the biliary tract, proximal to the influence of the right and left. So here we can see the hepatolithiasis. Hepatolithiasis means stone or biliary tract proximal to the confluence of the right or left hepatic duct. Okay, so if we consider this, there is the I have to select the color green, and when there is the confluence of the right and left hepatic duct, if there is a stone proximal to the confluence, proximal to the stone, proximal to the confluence is considered as the biliary tract. Okay, now classification. The classification, if we observed it, there is one when there is 5 classification. Type 1, when there is no stricture and intra and extra hepatic biliary channel, and type 2, when there is a stricture in the lower bile duct or ampulla of duodenum, and if we observe there are types of type of duodenum or type of structure. Type 1, there is no structure. Type 2, there is a structure in the low. If we observe there is a structure, what is a structure? The structure is in the lower bile duct or ampulla, remarkable dilatation in the biliary channel. And if we observe that type 3, the structure is and the confluence, this is known as the confluence of the right and left hepatic duct. It is the type 3. It is the type 3. Now if we observe the type 4, there is stricture either in the right side or the left side of the duct, and this is considered as type 4. And type 5, if there is either side stricture present in the right and left hepatic duct, it is considered as type 5. Okay, so if we have to describe the management is consists of the clinical feature, then lab investigation and treatment. So if we consider clinical feature, there may be various kind of clinical feature. One may be asymptomatic and some may be also symptomatic. So if there is a symptom, the symptom usually consists of cholangitis. Cholangitis means a recurrent upper abdominal pain, fever, iver, and less frequently jaundice. And there are some symptomatic if you consider symptomatic, there is also features of septic shock. If we go for the investigation, we have to do the following thing, that we have to do the CBC, liver function test, CT scan with contrast, MRCP, and Parker's transoptic cholangiography. In the CBC, we can see what is the level of hemoglobin and is there any anemia present or not. Liver function test, we can see what is the condition of the bilirubin, is there any transaminitis or ALP is raised, and then GGT is raised, 5-nucleotide is raised, and iron deficiency anemia is raised. CT scan for detailed objective information. MRCP and Parkinson's transhepatic cholangiography. And now we have to go for treatment. Our treatment depends on the management of cholangitis. Our goal of treatment is through complete clearance of the stone and elimination of bile stasis. So our it depends on two things. I call a complete clearance of stones, complete clearance of what? Stones, and another elimination of bile stasis. Elimination. So elimination of bile stasis, complete clearance of stones. So we have to remove these two factors. One is stones and another is bile stasis. Now we have to go for surgical management. For the surgical management, there are various options present. One is segmentectomy. If we consider this as a liver, there are various kind of segment. Various kind of segment. If we can go for segmentectomy. Okay, the segmentectomy, or even we can go for a lobectomy. An indication. What are the indication? Indication, there may be unilateral indication when there is unilateral hemiliver. So I actually don't understand what is unilateral hemiliver. For that reason I go to Bloomgard, and from Bloomgard I found that when the one side of the liver is atrophied with severe bile duct stricture and dilatation, and liver resection should be considered. So there is liver is atrophied. So here it is written atrophy of liver and severe bile duct strictures. So biliary stricture. So these two criteria is considered as unilateral hemiliver, because if there is stricture of bile duct and as well as atrophy, this is unilateral hemiliver, and there may be also presence of ICC. There may be also presence of ICC. There may be also presence of ICC. Intrahepatic cholangiocarcinoma. Okay. So bilateral hepatectomy and hepatocolitomy plus T-tube. We can go for hepatectomy, resection of the liver, and then we can also insert T-tube. Okay. So this is the can also insert T-tube. Okay, then there are several other options. We can go for hepatectomy. We can go for hepatectomy and hepatojejunostomy with jejunal access loop. Here it is written that when there is jejunal access loop, you can go for hepatectomy and hepatojejunostomy. Hepatectomy and hepatojejunostomy. Okay. Hepatojejunostomy. Okay. Post-operative stone removal from tissue, and we can even go for bilateral partial resection of liver, and there is increased resection recurrence rate 11.8, and if urinary resection recurrence holo 34.1. What is the indication of liver transplantation? Indication of, we can go for liver transplantation. Okay, we can go for liver transplantation, and the indications of the liver transplantations are if there is repeated cholangitis. So here, by seeing the corrugated area, we can understand there is repeated cholangitis, and multiple operation. There is multiple time patient underwent under the scalpel. Patient for the multiple time underwent scalpel. Okay, then diffusely distributed hepatolithiasis. So hepatolithiasis is diffusely distributed. Diffusely distributed hepatolithiasis, we can go for surgery. Colonoscopy clearance of T-tube in CVD and hepatojejunostomy. Okay. So that's all for today's. What we have learned the classification of hepatolithiasis. Then we learn about the management by clinical feature investigation and treatment. From the clinical feature, we at first say that patient may come asymptomatic, then after asymptomatic, patient may also present with a upper quadrant pain and symptomatic features of cholangitis. Then there is important feature of septic shock. Feature of SS stands for septic shock. Then investigation. Treatment. Investigation, we will give some common investigations, CBC liver function, common investigations like CBC liver function test, CT scan with contrast, MRCP, PTC. Then we go for treatment management of the cholangitis. For this reason, we have to go for resuscitation of the fluid. Fluid resuscitation is very important. Antibiotic application is very important. Invasive monitoring, this is very important. We have to go for monitoring. We can monitor the patient by multi-parameter monitor. Okay, then we have to go for treatment is to complete resection of the stones and elimination of the bilateral. Surgical treatment holo segmentectomy or lobectomy. Indication ki unilateral hemiliver biliary stricture atrophy and presence of intrahepatic cholangiocarcinoma. When Outside the liver is atrophied with severe bile duct structure and dilatation. Liver resection should be considered. Bilateral hepatolithiasis. Bilateral hepatectomy. If previously we have discussed about the unilateral hepatectomy. Bilateral hepatectomy, and we can go for hepatectomy plus T-tube, and we can also go for excess loop to provision for the removal of the stone by Rho and Y hepatic hysterectomy. And we can go for liver transplantation. For the liver transplantation, first is the first unilateral hemiliver. Repeated cholangitis number one হলো repeated cholangitis, and then we have to go for multiple surgery and a bilateral partial repeated dissection of the liver. So the classification of hepatitis. So today that's all from our side. Thank you for your patience, Yuri.